Hello, and welcome to today's webinar, part of an educational program on innovation in duodenoscope design from the AGA Center for GI Innovation and Technology. This program is supported by an educational grant from Boston Scientific. And today we're going to hear from my excellent colleagues who are the experts in endoscopy and hopefully will shed some light on the pros and cons of innovation in duodenoscope design. Darsh Thacker is my co-director for this program at UCLA. Jay Prashrika, it says Hopkins, but he's the soon-to-be chief of medicine at Scottsdale Mayo. Brett Peterson, ASGE president and at Mayo Clinic. It's nice to have some cross-society discussion. And then Amy Tyberg is at Robert Wood Johnson, and everyone is excited to share their editorial experience and their experiences with us today. Here are disclosures. And today's webinar is going to focus on infection control and endoscopy, changing the landscape through new and improved designs. Now, this whole program is a multi-part educational program that's going to be focused on innovation in duodenoscope design. We have a dedicated microsite. We've had expert editorials, 3 of which we're going to discuss today. And this is the second of our webinars. And our goals are to understand the current directions and recommendations for these duodenoscopes based on current FDA guidelines and perhaps where they're going to go in the future, and assess what the data is currently and what is the future direction of this field and how is it going to impact our GI practices. For our audience, we have a couple poll questions just to get a sense of where everyone's kind of stands in terms of using the currently available disposable scopes or disposable components on scopes. And the first poll question for the audience is, what % of your ERCPs are performed with disposable caps? Sadly, the panel cannot answer this. We'll give it a few seconds. But I guess on the panel, how many are using disposable cap scopes currently? We don't have the scopes yet, but we're about to transition. So Amy, Adarsh, you're using them, and Brett. No, Brett, you're not. Oh, you're muted. Okay.
Yeah, for me, it's depending on which site I'm at. So different facilities have implemented different solutions. So it kind of depends on which hospital.
Okay. Well, it looks like we have anywhere, from none all the way up to more than 75%. So a variety of experiences. And then we'll show our second poll question. What % of your ERCPs are performed with fully disposable duodenoscopes? I'll say at University of Chicago, it's probably less than 25%. But, and Adarsh, you were saying depending on your hospital?
Yeah, exactly.
Brett, you have to be the same every day. No. Amy?
Yeah, for us, we're 100% either caps or single-use scopes at this point, but I would say probably closer to in the 10 to 20% single-use scopes.
I was going to say, I don't know your experience, how it's going to change between Hopkins and Scottsdale Mayo in terms of what scopes they use. Uh-oh, you're muted.
I don't know that myself, actually, but I think Hopkins, like other medical centers, is in transition, and there's a lot of pressure to switch to either one of those categories.
I think this is great, just highlighting the variety we're seeing at different institutions and how this topic, is changing on a daily basis depending on what the data or the new FDA recommendations are. And so for this question, our audience is a little bit less in terms of fully disposable duodenoscopes, but anywhere from none to 50%. So it does seem like our audience is utilizing this new technology. So we'll get into what the problem is by my co-director, and then our various editorial recaps.
Sure. Thank you, Uzma. All right, we can move forward to the next slide. So at this point, I think it's well known that there have been multiple exogenous infection outbreaks linked to duodenoscopes with cross-contamination between patients. And as Dr. Siddiqui had mentioned, there's ample content on kind of laying the scope of the problem on the website. But kind of there's three patterns that seem to be emerging. One is that these devices are complex, particularly with duodenoscopes. The elevator mechanism was implicated as a major source of potential infection, but other studies have shown that perhaps other parts, some of the water channels, maybe some defects within the working channels or other areas can also potentially harbor infection. So the devices are complex. There's also been uncovered kind of issues with the reprocessing or cleaning steps. Potentially, there's too many possibilities for human error. There may be issues with what types of detergents, what kind of cleaning agents are being used. And so there's a lot of attention given to how to clean the scopes better and reprocess them. And then also, thirdly, I don't know that we really have an idea of how bad this problem really is, because there's issues in variability with reporting infectious outbreaks, and not something that most people want to publicly advertise. But tracing these infections, detecting them in the first place, very difficult. And so these have all kind of contributed to where we stand today. And there were kind of short-term solutions initially defined by the FDA and recommended, maybe some issues or some suggestions on how to reprocess differently, how to kind of trace infections, make sure scopes are clean, et cetera. But now, kind of years later, after the last kind of highly publicized outbreaks, there's been several innovations in duodenoscope design, maybe potentially serve as longer term solutions. And so with that, we'll kind of go forth with the webinar here.
Okay. Thank you so much for having me. So we can go to the next slide. So as this issue has kind of risen in awareness, it's also come to the attention of the FDA. And one of the, these are just a few of the important statements that they put out over the last couple of years. Basically, the biggest one started in 2015 when the FDA made a recommendation that all manufacturers who make duodenoscopes that are sold in the United States had to conduct studies to better understand how these scopes are reprocessed in the real world. And what they found when they looked at the data from the study was that there was much higher rates of contamination after reprocessing than they anticipated, which kind of inspired the next recommendation, which came around 2019, which was that the best solution to reduce the risk of infection transmission via duodenoscopes was through innovative device designs incorporating disposable components. And they took it even further just recently in 2022, where they actually made a recommendation that hospitals and endoscopy facilities should be transitioning to these new innovative designs that include disposable components or to fully disposable duodenoscopes. Next slide. Yeah. So what do we mean when we talk about these innovative designs? And there are basically two options that we're talking about. The first is the single-use duodenoscopes, which are the fully disposable duodenoscopes. And there's currently two of these scopes available on the market today, the A scope by Ambu, as well as the Exalt Model D by Boston Scientific. And the other innovative design is the duodenoscopes that have disposable caps or tips, known as the disposable components duodenoscopes. And there's actually 4 of these available right now in the market in the US from Fujifilm, Olympus, and from Pentax. Next slide. When we talk about the data behind using these novel duodenoscopes, it's really the Exalt that has the most published data so far. This is one of the first studies. This was a bench study that was published in 2020, where 6 expert endoscopists performed 4 ERCP tasks with 4 different scopes, 3 different reusable duodenoscopes, as well as the Exalt Model D. And what they found was that when they looked at the completion times to complete the tasks, the ratings, the subjective ratings by the expert endoscopist, the tip control, the image quality, and the functionality and completion of the task, it was really similar between all the scopes. But what they did find was that the navigation and the pushability was a little bit worse for the single-use duodenoscopes. Next slide. This kind of prompted the next human study. This was also published in 2020. This study involved 7 ERCP experts at 6 academic medical centers who performed 60 ERCP cases of varying complexity, from very simple to more complex ERCPs. And they looked at several different outcome measures. They looked at the completion rate with the single-use scope alone, as well as the need to cross over to a reusable scope, as well as the adverse events. But they also had these experts rate the scopes on 14 different ERCP maneuvers, either as not preferred, neutral, or preferred compared to the reusable scopes. They also had them rate them on 23 ERCP performance characteristics, and that means things like suctioning and image quality and things like that. And they were scored from a scale of 1, which is not preferred, to 5, which is comparable. And then they asked for the overall satisfaction in performing the ERCP with the single-use scope on a scale of 1 to 10. And what they found was that actually 97% of the ERCPs were able to be completed with the single-use duodenoscope alone. There were 2 cases where there required crossover to the reusable duodenoscopes. The adverse event rate was 6.8%, but most of these adverse events were related to the ERCP procedure, specifically post-ERCP pancreatitis, sphincterotomy, bleeding, and 1 patient that had progression of a already established infection. Of the 177 ratings that they got on the different maneuvers, 92% were rated either neutral or preferred, the majority being neutral. And they had over 1,000 ratings on the ERCP performance characteristics, and 98% of them were scored as a greater than 3. And the overall median satisfaction was 9, with a little under 7% being scored less than 4. Next scope. This is a randomized control trial that was subsequently done. This was where the EXALT Model D was compared to a standard reusable duodenoscope. In this case, it was the Olympus scope. It involved 98 patients that were randomized, 48 to the single-use duodenoscope and 50 to the reusable duodenoscope. And what they found was that the number of cannulation attempts was actually lower in the disposable or the single-use group. The ease of passage, image quality, image stability, and air-water functionality was a little bit worse in the single-use duodenoscope group, but there was no difference in the rate of cannulation, in the adverse event rate, and in the need for advanced cannulation techniques or the need for crossover. So I think what we can take away from this data is that there is some differences in using these innovative designs, and some of the usability, the maneuverability scored a little bit lower, but when it comes to actually performing the procedures, they were pretty comparable to the reusable duodenoscopes. And I will stop there and pass it along.
Uzma, you're muted.
I was saying I can't wait to hear everyone's preferences or opinions on how easy it is to use these scopes compared to our current fleet of duodenoscopes. So now we have Jay Prashrika, who is going to discuss his editorial on emerging post-marketing data on the new duodenoscopes. And I love the title, "We May Be Losing the War and the Peace." Already sounds controversial, so.
I'll thank you, Uzma and Adarsh, for inviting me. And thank you, Amy, for setting the stage. And what I wanted to do in the next few minutes is go beyond the randomized controlled trials in low complexity cases to the real world. You summarized the issues well. We have these 2 kinds of new innovations in duodenoscopes, the removable caps or the removable components, and the single use. And both have potential theoretical problems. Even though you have a removable cap, you still have new crevices and recessed areas to clean. And of course, there's a risk of losing the cap, which we have seen now. And then with the single-use duodenoscopes, it's basically you're trying to make a 65,000 plus state-of-the-art duodenoscope and reduce it to a 3,000. That's like saying, I'm going to take a Mercedes-Benz and make it for the price of a Yugo. But we'll talk about the data. Let's go on. Next slide, please. Can we go to the next slide? Okay. No. Sorry. Okay, so let's look at the MAUDE data. You're all familiar with the MAUDE data. This is the now requirement by the FDA to report problems with duodenoscopes. So when you look at 2021, which is the first year when all new innovations were in the market, we already start seeing a pattern. There's a lot more patient injury, as shown by the blue columns. With the removable cap scopes, there's also significant injury with the single-use scopes, and there is some, but it's relatively small with the conventional scopes. Similarly, with performance failures, the new innovations seem to be doing less well than the conventional scopes. Now, with respect to contamination, the net effect is not zero. Even with the removable caps, we can see, for the reasons I mentioned, because of the crevices that are hard to clean, there is still a significant contamination rate. It is certainly less than the conventional scopes, and as you would expect, with the completely disposable scopes, there will be no contamination. And you go to the right side, and we only have data for the first 6 months of 2022, the first half of 2022. You can see these numbers are actually starting to go up. Now, the scales are a little different, but overall, patient injury and performance failures have really multiplied. There are performance failures in the conventional endoscopes, but that's perhaps a reflection of the fact that these are now really outdated and there is no pressure to replace them with the conventional endoscopes, but to buy the new scopes. And again, the contamination rate with the disposable caps is still significant. It's about a third of that of the conventional scopes. Next slide, please. Now, we talked about this earlier in the survey. We tried to get at this answer. Part of calculating what the relative risk is based on what the denominator is. Now, the MAUDE data, unfortunately, doesn't capture the denominator, i.e., doesn't capture how many of these procedures were uneventful and being done with those kinds of scopes. But if you take some scenarios, as I've done here, if the new scopes are at 10%, which is possible, but perhaps it's an underestimation, the relative risk of injury or performance failure is 50x that of conventional endoscopes. If the new scopes are at 25% in the first half of 2022, the relative risk of injury or performance failure is 16x. And the new scopes in the first half of 2022 were at 50% of, those roughly 700,000 to 1 million ERCPs that are being done. The relative risk of injury or performance failure is still a very high 5 to 6x. The relative risk of contamination is shown in the row below. And at 10% is still 3 times higher. At 25%, it's about the same as conventional endoscopes. And if today, in the first half of 2022, new scopes are being used at 50%, then it's true that there is a reduction in the contamination rate. But to emphasize, it is not zero, which is why another title for my talk would be, are we throwing the baby out with the bathwater? Next slide, please. So are we safer? The AG objective is zero risk. It's not replacing one risk with another risk. And this is something that is puzzling to me, is when the FDA recommends that, they have yet to pass a public statement on the data that's coming into their scrutiny in MAUDE, looking at these kinds of injuries. We have people coughing up duodenoscope caps 2 days after the ERCP. That is a signal that these designs are not necessarily ready for prime time. I'd love to see the day when they are. They're just as safe and as effective, but we're not there yet. And so it's premature to call for recommendation and put pressure on hospitals and physicians to make that transition. The reduction of contamination cannot come at a cost of patient safety. And patients depend on us to make sure we're looking out after that. Next slide, please. And this goes back to my favorite topic, which is biodesign, and that's what I do. Do we have an innovation gap? It all depends on how the problem is framed. The current framework is contamination is inevitable. So all solutions that are being advocated are post hoc, after the contamination has occurred. So you either throw away part of the scope, which is the disposable cap solution, or throw away all the scope, which is the disposable duodenoscope solution. But the correct framework from a biodesign perspective is how to prevent contamination in the first place. And now you all know I have a conflict of interest. So the next slide has to be taken with that in mind. Next slide, please. There is an FDA-approved product that completely seals the distal end of a conventional duodenoscope and has been proven in extensive microbial studies to prevent contamination of the scope in the first place, and further to prevent dissemination of an infected scope to the patient or to the external environment. It is cheap. It does not require a change in scopes, and it's out there. Now, it's not the only solution, but I'm trying to put this in the context of how we at CJIT and the AGA should be thinking about the problem. We should be thinking about preventing contamination in the first place, because everything else may not be cost effective, it may be risky, and comes at a cost. Thank you.
Brett?
Yep. Did you have a poll or something coming?
No, I was just saying, I was encouraging the audience to put some questions into the chat box or the Q&A box.
Okay. Well, what does the future hold? This is kind of an enviable position because it's not data-based. It's very conceptual and forward-thinking, and that's actually what Dr. Pashrika does commonly with his innovative initiatives. I think the near-term future and what it'll hold for each of us in our own decision-making in our individual units will be highly dependent on pending data and data that should be accruable and is really necessary for some of our decision-making. And in the longer term, I think the future holds some unknowns regarding innovative designs and methods, which I think will resolve or lessen some of these challenges. And we've already heard about one of them, but I suspect there'll be others to come. Next slide, please. So what are some of the data points that I think we need to know? Well, first of all, there are ongoing 522 culture studies mandated by the FDA for the new legacy scopes that now have disposable caps. And these are completed by one of the companies with the smallest series mandated. The other two won't be back until spring. And I agree with the suggestion that these won't be perfect, they won't be sterile, but they'll be much improved, hopefully. The data we've seen is uncontrolled, kind of randomly submitted data suggests that they're better, but not still where we would like them to be. But it may give us some greater sense of comfort in using the disposable cap instruments when combined with other modalities. So the maturation of real world data means rather than a lot of the conceptual thinking and comparative studies in utility from an efficiency standpoint or a cost standpoint, we really need true data with these new instruments that are just on the market regarding their durability. The single-use instruments, we really don't know how durable and how well performing they'll be when they get into hundreds and thousands of cases. What will their safety be? I don't think they'll be egregiously high, but there's a lot of data that we need to learn from larger volumes of studies. The utility and efficiency are one of the sales pitches for these instruments. And I think we have a lot to learn there as to how they fit in a practice. And lastly, this issue of culture positivity, which is the only endpoint we have for our washing or our cleaning, high-level disinfection at this time. How does that correlate with infection transmission? And how does that correlate with actual infection as opposed to microbial transmission? This is data that we don't have a good handle on, and with new instruments that we'd like to see. What will the financial coverage be by payers for the single-use instruments once the current CMS pass-through codes are done? There's a presumption that this will lead to gradually increasing and eventually complete coverage for these instruments, but that will be an unknown that will influence many institutions. And then what's the cost benefit as opposed to the recent modeling? What's the true cost benefit of single use versus disposable cap versus other modalities, such as we've just seen from Dr. Pashrika, as well as from high-level disinfection versus sterilization. Next slide. We do have some modeling data, and this was from Dr. Barakat and Banerjee and others at Stanford, looking at the cost analysis of minimizing risk of duodenoscope-related infections with a Monte Carlo simulation. And next, advance. They looked at high-level disinfection, double HLD, ETO sterilization, culture and hold, an expensive and laborious process, partially disposable duodenoscopes, and fully disposable, with attention to quality of life years lost by infection that's transmitted. And next slide for results. Their results could be concluded in the bottom line that single-use instruments were optimal for environments where the transmission was greater than 1%. And this transmission in this study correlates to infection. And partially disposable removable caps were favored if transmission was less than 1%. And then they had other comparators, such as the legacy scopes with ethylene oxide. But legacy scopes won't be available to us beyond a year from now, likely. Next slide. So Dr. Bang in Orlando and colleagues also did this analysis of the cost per procedure of an instrument and reprocessing, and correlating that with the volume of a unit. So way over on the right-hand side, that comes down to a little over $100 per procedure if you're doing 2,000 or more ERCPs in a year, much like my institution. But as you move to the left, cost per procedure really accelerates. And there are many, many, many units in our country that do less than 200, even less than 100 ERCPs per year. And the cost quickly escalates up to $600 or $800 per procedure. And that's an environment where a single-use instrument becomes far more attractive. And next slide. Now, if one factors in the expense of caring for transmitted infections at these different rates of transmission, then the cost per procedure accelerates for all environments. And you can see about 2/3 the way up in purple, we have that 1% transmission and infection rate, which I'm not sure will prove to be the case long-term as we use these newer instruments. Recall that the majority of infections, many of us believe, are translocation rather than transmission after an ERCP. Next slide. So this whole question of single-use versus reusable is replicating what we went through with a lot of angst about 20 to 25 years ago for devices. Should we use single-use sphincterotomes or or reusable sphincterotomes? And you can see there are pros and cons for each. For reusable devices in general, we've thought they have superior design, durable construction, they're very reliable. They may have a lower lifetime cost if you're in a high volume center. And we used to think enabled great complexity compared to the disposables. On the negative side, they're hard to clean and reprocess. They risk transmission. They carry liability for our institutions. They have expensive reprocessing, and they require some degree of storage and keeping of inventory. In contrast, the single-use we've already heard, are always sterile at the outset, no risk of transmission. This helps with our institutional risk management on a global basis. We've not yet talked about the utility of design change, which can happen very rapidly in an iterative fashion based on needs. And then there's certain efficiencies of time and place. It may be that single use will be ideal for middle of the night, an ERCP in an intensive care unit or in an OR, when staffing is short, when reprocessing machinery or personnel are inadequate for a given shift. So there may be a place for all of us with that device. The downside being, up until now, we've had a question about function. They're proving to be efficacious, but will they really stand up to the kind of abuse that we give a scope over difficult, long, lengthy procedures? We don't yet know. They are expensive comparatively. Recycling and the waste stream has manuscripts and abstracts favoring one instrument or the other, but in general, in this current era of climate change, this is a legitimate concern that I think we need a lot more data on. The continuous purchasing, the complex supply chain, the need for space and storage are probably greater with single use than with the reusable. So there's pros and cons to each of them, and these considerations may vary for each of our institutions. Next slide. So innovative designs will hopefully be coming forward, and many of these we've already seen inkled in abstracts and in preliminary publications. Reprocessing, cleaning, and sterilization modalities are changing gradually. We know there are novel washing modalities that are less operator dependent. Some of them are already FDA approved and have been shown to remove biofilm, but they're not yet widespread in the marketplace. Tabletop ETO for a single small center has already been available for several years, FDA approved. Other modalities that will do a better job with the long lumens of our instruments, where they're already in use for other kinds of instruments, are in development, and I'm sure will come to the marketplace in the next 3 to 5 to 7 years. And lastly, this issue of iteration in endoscope design. A legacy instrument can certainly iterate, but the expense and the marketplace for that iteration is small on a per type basis. But one can imagine scopes with different lengths, caliber of channels, channel size, lens orientation, grip size for large hands, small hands, maybe by gender. We know there's great differences there. And the functional controls. So these might be purpose specific. They might be specific to patients or specific pathologies. There's talk of bleeding scopes that look at certain angles, or they might be endoscopy specific for preferences. So there are a lot of situations for which the iterative designs and rapid change that might be available in a single use are quite attractive. Next slide. So that's it. I think in the future, it won't be all one or all the other. I think there will be a mix of designs, and each center will have its different needs based on the complexity of their practice, the volume of their practice, the makeup of their practitioners, and what comes down the pike in the next 5 to 10 years. So thank you.
All right. Thank you to all our wonderful speakers tonight. We have a few questions in our chat box. Heiko Pohl, thanks for putting up a question. He said he had a couple points. He agrees with Dr. Pashrika that the main question is what we're trying to achieve, but is contamination-free scopes the right question, since we don't know if contamination equals risk of infection? And then also, they wanted to mention the recent study by Wynn et al. That looked, I think that was the one from February in GIE this year, that looked at single use versus reusable scopes with caps, that looked at greater health impacts of disposable scopes and a 20-fold greater environmental impact. So two things. I guess one is, are we asking the right question? Does contamination equal risk of infection transmission? And are we setting the bar too high? Jay, I'll let you start.
So my framework is prevent contamination both ways in the first place. This is the reason surgeons wear gloves, right? They want to prevent themselves from getting infected, and they want to prevent the patient from getting infected. And that's what we need to strive for. Why even bother with that question if we can prevent contamination in the first place? Everything we do after contamination occurs is going to be to try to answer possibly an unanswerable question, because it'll take thousands of patients to study. I do agree with what Brett said, that there may be a room and a niche for these innovations. For instance, a completely disposable duodenoscope for high-risk patients. Absolutely. If I had a high-risk patient and I had a disposable duodenoscope that performed just as well, right? Now, remember, this is a high-risk patient. I have one shot at it. I don't want a performance failure, and I don't want to say I'm going to have to change it out. So what's missing in all these papers that have been quoted in terms of the cost and the utility has been the fact that the MAUDE data is showing there is a risk for patient injury and performance failure that is actually a lot higher. And this needs to be factored in both by us as practicing endoscopists, but also by the regulatory agencies.
I'll stop you right there. So Brett and Amy and Adarsh, we can discuss maybe a little bit about this discussion on MAUDE data and how flawed that probably is on new devices. But go ahead, Brett, you're shaking your head, or Amy, want to comment?
Well, I think the MAUDE data is very helpful for demonstrating a signal that things aren't perfect with any one of these options, and a signal that there's more we need to understand and know about them. But the reporting to the MAUDE system is voluntary by hospitals. It's not voluntary for manufacturers. But I just don't think we can compare rates. I don't think we can compare ratios of reports to potential use. I think it's so random and so varied, especially for a new device where it's likely to be more common than for an established device where certain presumptions are already accepted, that I think the MAUDE data is being overemphasized. It remains important, but I don't think it gives us any answers.
I know, Amy, I've never reported to the MAUDE database on any complication or issue I've had with a scope, but.
Yeah, I don't think we have either. I agree. I think we have to factor in the learning curve. Whenever you have new technology, it takes them getting used to. And I will say, at my institution, we're using 100% either disposable caps or single-use scopes. We've completely transitioned over. And, in the beginning, when we started using the disposable caps, we did have a couple that fell off during the procedure, but it was actually more of an education issue than anything else. And we sort of retrained the techs and the nurses that are attaching the caps at the beginning of the procedures. And once we did a couple more in-services and better education, we've had zero since then. So I think you have to take this data with a grain of salt, that this is very early in this technology. And, there is a learning curve, there's education that has to happen. And I think those numbers are going to flatten out as people become more comfortable and get more used to using these scopes. The same with the single-use scopes. I think you have to sort of understand that the shaft is a little bit stiffer, and when you're pulling out the scope, you have to actually turn the big wheel to straighten the scope before you come out, or you can cause injury that you wouldn't with a. So I tell my fellows, straighten out before you extubate.
So let me respond to that.
Yeah, that's it.
Let me respond to that.
Yeah.
Who's paying the price for this learning curve? Your patients are.
Yeah, but that's
no, it's not necessary.
Over the years.
Let's just stop.
If you use
for a second, let's just stop for a second. If you have a new technology that is, if you have a new technology that is operator dependent, requires training, then enough time and effort should go into making sure that that training is in place.
That is true.
That's
The
right.
patients don't have to pay the price for your training as you adopt a new technology. That's the point I'm making. I'm not disagreeing with what you're saying. I'm just saying we need to say who is paying the cost for your learning curve.
But they're also, she's saying it's just kind of an education as with.
Yes, so where has been the effort to educate and
There is
train
the effort. That's
people
why,
in using these scopes?
but there is an effort by the companies, these
Then
programs.
there should have been no patient injury if these things were known beforehand.
But
We
still
are
have
testing them out in patients
usable
and
scope.
saying, this is what you need.
I
But
think it's
before
so
we go to
hard
patients, a safety record should be established for any new device, just as we expect and as patients expect.
But we're establishing it now with the
No,
data.
but we are having perforations in 2021 that were unheard of with conventional endoscopes. We had 100+ perforations. We have had perforations with the disposable duodenoscopes. That's not right. Who's paying the price?
But also, do you think that the perforations happening with a reusable scope, they're not, you're not seeing them in the MAUDE database, so you're kind of skewed towards the new devices?
No.
But I agree.
So with the conventional endoscopes, perforations, if they happened because of a technical problem with the scope, right? That should be reported. That's mandatory. If they happen because it's inevitable as part of an ERCP, that's fine. That's not, we're talking about scope dependent errors, technology dependent errors.
We'll go over one more topic, but we'll all agree that patient safety is paramount, and we all are learning and educating ourselves and our colleagues on how to use these scopes safely. So one other topic that two of our comments in the chat box brought up was the carbon footprint. So you have the new devices, these disposable scopes that are supposedly have recyclable product, aspects, but not completely recyclable. What is the carbon footprint impact for those? Also, it was brought up, the carbon footprint that we have from our sterilization, ethylene oxide polluting hospitals, neighborhoods' air. So, which one is better? And do we know enough to say right now? Brett, I don't know if you've read the initial draft on the multi-society paper that's coming out soon. I think trying to discuss some aspirations for our future in GI and minimizing our carbon footprint.
Yes, I have. And I think this is an extremely important point and question as to what's the end result of a single-use duodenoscope? Well, and what's the corollary effect on the carbon footprint of reprocessing? So I know there have been a number of early studies and reports, but I think we need to understand that in a more definitive fashion for all of our benefits. And that won't remove either one from the marketplace, but it might influence many of our units as to how we use them, what volume we use them in, what frequency, whether they're preferential or non-preferential.
And I guess the paper that Heiko brought up that was published this year in GIE mentioned a greater than 20-fold environmental impact with a disposable scope. So again, as you said, we need more data. And also, the companies right now say, oh, we won't charge you to help recycle these scopes with the completely disposable scopes. But I don't know in the future if that will be free, and then that will be added cost to every procedure as well, how we clean the scopes or dispose of them.
But that's rolled into the price. So it's not the issue of the finances, I think, as much as it is the end result of the recycling.
I was going to say finances always come into it. Safety first, then finances. But Amy, and then I'll let Jay maybe have the last word. But
yeah, I mean, I agree. I think it's a question that we still need a lot more information. You have to weigh, yes, these scopes are being recycled, but I think the majority of the scope is actually reused, whether it's, not for another scope, but it's used in, tires or other things that, recycled plastic gets used for. But you have to weigh that against, the chemicals that we use to process the scopes, which are extremely toxic to the environment. So I think it's very hard to quantify, and I agree, more information is needed, but I don't think it's a clear slam dunk one way or the other, which is better at this point.
Jay, any optimism?
So I just want to go back to the safety issue that you brought up, right? And I'm going to stop after I say this. So does the panel think that the disposable caps or the disposable scopes are as safe and as performance effective as what we used to have with the conventional duodenoscopes? It's simple yes or no. Yes, you believe that they're as safe or not? Because if you don't,
You asked safety and efficacy. So
yes, if you don't, then a year from now, we're going to be stuck with relatively less safe and perhaps less performance effective scopes, because that's where the mandate is going. And we'll be stuck with them. So I'm asking you, if you believe that there is a reasonable doubt, I'm not saying believe in the data, you brought up fair questions about the MAUDE data, but if there is a doubt in our mind that they may not be safe and they may not be as performance effective, then we need to hit the pause button before we are all stuck with this.
Yeah, I'll make a comment just because I go to different hospitals, so I've had a chance to use really all of these designs, and I hear you on wanting a yes or no answer, but I really think that the answer is it as safe as the first 10 times I passed a reusable duodenoscope or a reusable echo endoscope? As a fellow, I remember the challenge of passing a side viewer for the first time. And so, yes, in the beginning, if I use the same muscle memory that I use for an Olympus or a Fuji scope, which I use at different hospitals, then yeah, I would have potentially caused a complication. But at one hospital, they upgraded from the old version duodenoscope to a new version, and then I've used the single uses, both of the models. So in the first 10 to 15 cases, sure, there's a little bit of a learning curve, but it's the same as when the first time I used it. So if I use the same muscle memory, then absolutely I agree that it's inappropriate.
Yeah, but others, we're not talking about training environments. We're talking about hospitals with endoscopists who are doing 100 to 200 ERCPs, and the mandate is on them to replace it.
I agree with
There's no training program in place.
But
there's no.
But I will say that once these issues were identified, there was a manufacturer notice to all physicians, and they were very upfront about it. They reported outright perforations. They're running lots of training. So I hear you, but again, I think one thing to step back is that treat this not as a replacement, but as a brand new device. I think that's
how many unnecessary perforations do we need to justify that in a patient?
perforations are a risk of any ERCP.
No, perforations are not the risk of any ERCP. We're not talking about any ERCP. We're not talking about, sorry, Usman, we're not talking about ERCP related perforation. We're talking about device flaw related perforations.
No,
there's a difference.
Perfect.
I'm making that distinction.
Okay. I think this is, again, an ongoing debate, and we're going to end on that. I want to thank everyone for participating in today's program. We had a great discussion and lively debate highlighting pros and cons of the new duodenoscope designs. And I'm sure that we're going to be hearing a lot more about all of this in the future, especially as the FDA mandates go into effect. We get more experience with these current scopes and designs. And, what I'm most excited about is to see what the future holds. And hopefully, we'll get to a point where everyone agrees that the scopes are safe, effective, and reduce our carbon footprint. Thank you, everyone. Thank you to all our panelists and speakers.
Thank you.
Bye-bye.
This is the second of 2 webinars within the Innovation and Duodenoscope Design Program. Please visit our program website, scopeinnovation.gastro.org, and to access additional educational content and share your perspectives, you can use our Twitter hashtag #ScopeInnovation. And thank you to the AGA's Center for GI Innovation and Technology for making this program possible, and Boston Scientific, our sponsors.